Okay, thank you, Professor Pangera. I'm happy to be here in Ho Chi Minh City today with you, and we're talking about genetic testing for male infertility. Okay. Shall we use, okay, we'll use a mouse. Okay. The history of studying genetic causes of male infertility is actually quite long. It began in 1957 when Malcolm Ferguson Smith described Barr body in a subset of patients with Klinefelter syndrome. Back in the beginning of the 20th century, when Harry Klinefelter, an American endocrinologist, described Klinefelter syndrome, it was considered to be just a subset of patients with hypergonadotropic hypogonadism, azoospermia, and a specific body habitus. But in 1957, Malcolm Ferguson Smith from Scotland, United Kingdom, he found Barr's body in a subset of patients with Klinefelter syndrome, which meant that at least a part of them had several X chromosomes, when a healthy male should have 46 XY karyotype with only one X chromosome. And beginning from 1957, only patients with 2 or more X chromosomes are considered to have Klinefelter syndrome. In 1968, Elvin Kaplan described absence of vas deferens in patients with cystic fibrosis. Cystic fibrosis was long known as a potentially lethal and a disabling disease which caused recurrent pneumonias and respiratory tract infections in patients. But it was Elvin Kaplan who found that all those patients have absent vas deferens, which meant that they were absolutely infertile if surgical sperm retrieval, which was not very common back then, if it wasn't performed. And finally, in 1976, Tipolo and Zaffardi described azoospermia factor in a long arm of Y chromosome. So if we try to classify causes of genetically determined male infertility, pretty much like any other type of male infertility, it may be classified into pretesticular, testicular, and post-testicular causes. Among pretesticular causes, the most well-known is Kallmann syndrome, which is a congenital hypogonadotropic hypogonadism associated with anosmia. However, there are many other types of hypogonadotropic hypogonadism, which is not exclusively associated with anosmia. There may be other types which may be also genetically determined as well. A rarely discussed cause of pretesticular male infertility is hemoglobinopathies, which are conditions which a man has a dysfunctional hemoglobin molecule. Man or woman for this cause, yes, but when we're talking about male infertility, boys who undergo frequent blood transfusion in childhood and later in adolescence and later in adulthood because of anemia, they may have iron deposits in their pituitary and rarely in their testes. But iron deposition in pituitary may lead to dysfunction of hypothalamus and pituitary gland, which may lead to hypogonadotropic hypogonadism as well. And if we're talking about testicular causes of genetically determined male infertility, those are mainly abnormal karyotype and Y chromosome microdeletions, which may lead to spermatogenic failure due to germ cell aplasia, which is typical for AZF-A or AZF-B mutations or Klinefelter syndrome, or to maturation rest, which may be observed in a subset of patients with AZF deletions and for patients with chromosomal translocations. Finally, there are post-testicular causes of genetically determined male infertility, which may be associated with cystic fibrosis mutations, which were already mentioned, and they may be associated with sperm dysfunction, or in particular in particular astenozoospermia, such as in Cartagener's syndrome, which is associated with primary ciliary dyskinesia. And finally, one rare cause of post-testicular male infertility is polycystic kidney disease, which is commonly ignored by nephrologists, by some andrologists, etc. But polycystic kidney disease not only leads to a presence of cysts in kidneys, it also leads to presence of kidney cysts in liver, pancreas, and in seminal vesicles. And cystic dysplasia of seminal vesicles may lead to obstructive oligozoospermia and finally azoospermia as time goes on and the cysts grow. If we talk about indications to genetic testing, there are Global Andrology Forum guidelines on non-obstructive azoospermia, which recommend performing karyotyping and AZF testing in all men with non-obstructive azoospermia. And CFTR testing is indicated primarily in patients with obstructive azoospermia, but in rare cases may be indicated even in non-obstructive azoospermia in regions with high prevalence of CFTR mutations. Exome and genome sequencing are mentioned in GAF guidelines, but not recommended as routine tests yet. If we are talking about other international guidelines, such as American guidelines or European urological guidelines, they are becoming more and more conservative in terms of cutoff values for karyotyping and AZF testing. Like several years ago, we should have performed karyotyping in all patients with sperm concentration below 10 million per milliliter. But today, American guidelines state that karyotyping should be performed in patients with concentration of sperm below 5 million per milliliter. And European Urological Association states that karyotyping should be also performed in patients with sperm concentration below 5 million per milliliter. However, there is still internal controversy inside European guidelines, which still continue to state that 10 million per milliliter is a valid threshold until further studies confirm 5 million per milliliter. AZF mutations, Y chromosome microdeletions, should be tested in patients with sperm concentration below 1 million per milliliter. But if, once again, we look to the European guidelines, they state that patients with sperm concentration below 1 million per milliliter must be tested. But those tests may be considered in patients with sperm concentration below 5 million per milliliter. However, the trend is obvious. The guidelines become more and more conservative in terms of cutoff values. For CFTR testing, we should test patients with a unilateral or bilateral absence of vas deferens, and what's most important, female partners of such patients should be also tested for CFTR mutations, even if CFTR mutation is not confirmed with PCR testing in a male, because cystic fibrosis is a recessive condition which requires at least two deficient copies of CFTR gene for a patient to have clinical manifestations. So we'll talk about it later. As for exome sequencing, it is also only discussed in EAU guidelines with such a statement that diagnostic yield of exome sequencing is increasing, but there are no obvious indications for it yet. Klinefelter syndrome is a classic cause of male infertility. As I already told before, Harry Klinefelter originally described patients with hypergonadotropic hypogonadism and typical body habitus as having Klinefelter syndrome. But today we only call patients with karyotype 47XXY or 48XXXY, etc., to have Klinefelter syndrome. So most of these patients have azoospermia, but some patients with mosaic Klinefelter syndrome may have oligozoospermia. They're thought to have the classic body habitus, which is tall, less muscular, with broad hips, breast enlargement, less facial hair, etc. But actually, the clinical phenotype is highly variable. I had a professional basketball player who had Klinefelter syndrome as my patient, so it's not very obvious. There is still a controversy over testosterone replacement to induce puberty in such patients because it is thought that testosterone replacement may hinder microTZ sperm retrieval rates in adulthood. And we know that sperm retrieval rates tend to decrease with age in such patients. About Jacob's syndrome, which is 47XYY syndrome, there are many controversies and misconceptions regarding this syndrome. It is very common. It is thought that almost 1 person per 1,000 newborn males has a syndrome. It is thought that most men with Jacob's syndrome are fertile, and about 85% of cases of Jacob's syndrome go undiagnosed. There are some thoughts that such patients may have tall stature, acne, tendency for crime and aggressiveness, learning disability, etc. But it's probably biased because some studies regarding Jacobs syndrome were performed in psychiatric wards and correctional facilities. So the population for the studies was biased from the beginning. Even if we consider that patients with XYY karyotype are fertile, there is still a risk of sperm aneuploidy because of presence of an extra chromosome, which need to be considered. Chromosomal translocations may be classified into balanced or unbalanced, considering whether there is a loss of or gain of genetic material. They may be reciprocal or non-reciprocal, and there is a specific type of chromosomal translocation which is called Robertsonian translocations, which were originally described in insects, in grasshoppers. Robertsonian translocation is a condition when two long arms of acrocentric chromosomes fuse together, forming a combined chromosome, while the short arms usually get lost or form a micro chromosome. Those conditions are not harmless because they may lead to a higher rate of sperm aneuploidy, and there is a controversial effect called interchromosomal effect after Schultz and Redfield, which may lead to meiotic arrest in a subset of patients. But it is controversial. Not all researchers think that this interchromosomal effect takes place, as there is evidence that, in fact, it may not be true. However, we sometimes see patients with azoospermia due to maturation arrest caused by chromosomal translocations. If we talk about Y chromosome microdeletions, it's a condition when the nature put all of the eggs in one basket, because most of the genes responsible for spermatogenesis are contained on a long arm of Y chromosome, which is also called azoospermia factor, or AZF. Patients with complete deletions of AZF-A or B are considered to have negligible chances of sperm retrieval, almost zero, basically zero, because no case report was ever published that has demonstrated the presence of sperm in patients with complete deletions of AZF-A or AZF-B. But patients with AZF-C microdeletions may have actually pretty good chances at sperm retrieval, and some may even be non-azoospermic and may be treated with endocrine agents. There are other risks associated with Y chromosome microdeletions, such as risk for somatic health, as such patients were demonstrated to have higher risk of seminoma and non-Hodgkin lymphoma, and sometimes an elevated risk of low stature or risk of psychiatric conditions. Also, Y chromosome instability may lead to low embryo quality and a higher risk of Turner syndrome, which means that pre-implantation genetic testing is required in at least some of such couples. CFTR mutations are known because of imperfect predictive abilities of existing assays, PCR-based assays, because there are at least 6 molecular phenotypes of cystic fibrosis and at least 1,800 CFTR mutations, which may lead to those conditions with obvious ethnic and racial differences. And there are also genetic polymorphisms which may alter penetrance of CFTR mutations. And when we are consulting a couple where a man has congenital bilateral absence of vas deferens, or CBAVD, they should learn that almost 4% of Caucasian women are CFTR mutations carriers. So it means that if a woman is a mutation carrier, the risk of cystic fibrosis or CBAVD in offspring is 25 to 50%, and if a woman is not a proven carrier, the risk is about 0.4%. The pitfalls of CFTR testing are that PCR testing has low sensitivity and low negative predictive value. It is generally thought that targeted sequencing works better for detecting CFTR mutations. We should pay attention to patients' history and family history, such as risks of which is bronchitis, recurrent pneumonia, sinusitis, etc. And sometimes vas deferens identification may be difficult. Patients may have palpable vas deferens difference on both sides, but inguinal portion of VAS may be absent, or a pelvic portion of VAS may be absent on one or both sides. Some patients with CFTR mutations have absence of seminal vesicles, which is associated with low semen volume and shifted and pH shifted to acidic side. Pre-implantation genetic testing may help us when a patient is a known carrier of CFTR mutations. This way we may use PGT-M to identify embryos with low chance of cystic fibrosis upon reaching, upon birth. And for patients with chromosomal translocations, PGT-A, which is searching for markers of 24 chromosomes to identify unemployed embryos, may be performed. Should we evaluate all patients with azoospermia or severe oligozoospermia for genetic abnormalities? Yes and no, because guidelines state that we should do this, but there are some possible exceptions, such as a patient with a known paternity or secondary infertility. But sometimes patient partner fidelity can be proven, and questioning partner's fidelity is unethical when a couple comes to you for a consultation. So this is not a 100% exception. Also, sometimes patients present documented normal or borderline results of semen analysis from the past, but we know that quality of semen analysis is questionable in some cases, and some genetically determined cases of infertility tend to worsen with age. There are some obvious acquired causes of spermatogenic failure, such as cytotoxic chemotherapy, but also it's not an excuse to abstain from genetic testing, because some patients may have a genetic defect which coexists with acquired causes of male infertility. Also, if you have a patient who have undergone cytotoxic chemotherapy and hematopoietic stem cell transplantation, it is useless to send him for genetic testing, because mainly we will have contaminated blood samples, which means that lymphocytes from peripheral blood in such patients are actually lymphocytes from a donor of a bone marrow, who can be a father or a mother of a patient, and this way we will have contaminated results. But in these cases, you may consider using buccal epithelium to study genetic material of a patient. The causes of male infertility, which we just discussed, abnormal karyotype, CFTR tests, and Y chromosome microdeletions, are just the tip of the iceberg, because there are numerous other genes which may be damaged, and patient may have infertility because of that. Such mutations are extremely rare, and it is unfeasible for industry to produce assays to study such rare causes of male infertility, which means that we may not have an adequate instrument to study those rare causes of male infertility. Some mutations of androgen receptor may be associated with infertility. Those are mainly Quigley-1 scale, which is minimal androgen insensitivity syndrome, because other types have obvious intersex conditions, or hypospadias, or cryptorchidism, etc. Mutations of enzyme-coding genes such as 5-alpha reductase and aromatase may also lead to male infertility. Though those two enzymes work in completely different fashion, their mutations may lead to male infertility. Also, some genes may cause structural abnormalities, anatomical abnormalities, intersexual conditions. Congenital abnormalities of kidneys and urinary tract may be also associated with male infertility, especially if combined with agenesis of seminal vesicles. Also, there are some mutations which affect sperm structure and function, such as globozoospermia, which is a genetically determined total teratozoospermia characterized by a lack of acrosome cap, and primary ciliary dyskinesia, which is associated with pulmonary conditions and situs inversus, or reverse position of internal organs of a male. And talking about future directions, next generation sequencing is becoming more widely used today. It's more affordable and more quick than it was several years before. The mainstay is whole exome sequencing, which is able to decode protein coding regions. And whole genome sequencing is more expensive and more time-consuming version of next generation sequencing, but it's able to decipher up to 98% of genome. Targeted sequencing has only confirmatory role for patients who have specific regions of interest, such as CFTR mutations. So, will exome sequencing replace traditional panel of tests, which include karyotype, AZF deletions, and CFTR mutations? It is possible, but you should know that balanced translocation and low-grade mosaicism can't be detected with whole exome sequencing alone, which means that classic karyotyping is still relevant and will be relevant in the near future. Among other future technologies which may take their place in diagnostics of male infertility, we should mention array comparative genomic hybridization, which is the use of fluorescent DNA probes to determine copy number variations or structural variation, which have been demonstrated its usefulness in Y chromosome microdeletion testing and detection of globosomia causes. Blocker displacement amplification, which is a technique when wild-type allele is blocked by a specific primer and rare variants are multiplied with PCR, which allows us to detect previously unknown mutations. And finally, epigenetic testing. It still has uncertain clinical utility, but in future it may help to identify patient-specific sets of modifiable risk factors, which will bring us closer to personalized male infertility diagnostic and treatment. So thank you for your attention. If you have any questions, we may discuss them.
Yeah, the question we make hereafter, correctly. So congratulations.